We are live.
Hi, good evening to everybody. My name is Dr. Priyanka, and I am a part of BSV's medical team. I'm a regional medical advisor in BSV, and I would like to welcome you all to today's Kogi session, season 2 and episode 12. Today's topic is ovulation stimulation and challenges and solutions. I would like to introduce our moderator, Dr. Chaitanya Shembekar. He is one of the most renowned gynecologists and doctor in the city. Dr. Chaitanya Shembekar is the managing director of Omega Hospital in Nagpur. He is a prominent infertility expert with more than 2 decades of experience in his field and was also a gold medalist in pharmacology during his MBBS examination. He holds two prominent diplomas, Diploma in Pelvicoscopy and Diploma in USG from Kiel School of Endoscopy in Germany and Ian Donald School of Ultrasound, Switzerland, respectively. He served as a PCP NDT Advisory Committee member for the Nagpur Municipal Corporation and has also been a member for several renowned boards such as AMOGS, ISAR, Maharashtra Chapter, and Madhav Netralaya Nagpur. He has published numerous research articles, papers, and presentations and has also attended many international conferences. Over to you, Dr. Shembekar.
Good evening, friends. As you all know, today's session is special for us, as we have with us none other than Dr. Bart Fosser as a speaker. And before we start with his pearls of wisdom, I would, in brief, discuss about the ovarian stimulation Indian scenario, and then we would be listening to Dr. Fosser because he has a vast experience. Dr. Bart Fosser, I would like to introduce to the audience, is a very renowned professor, a professor emeritus of reproductive medicine at the University of Utrecht, a world leader in reproductive medicine, and a member of the board of Dutch Medical Research Council. He became fellow adjunct at the September 2015 fellowship ceremony at Royal College of Obstetrics and Gynecology, London, UK, and he has had profound influence on modern clinical practices and has been largely responsible for several key developments in the field of infertility, including an international consensus on definition of PCOS. Professor Fawcer serves on many international editorial boards and has been active in many international societies such as IFFS, ISG, and ESHRE. He has a postdoctoral Fulbright scholar in the Department of Reproductive Medicine at University of California, San Diego. And as we have also got an opportunity to listen to Dr. Fawcer on many occasions, and he is actually instigating worldwide trade towards milder and less burdensome and safer IVF practices. And this is something I think which is the need of our. He is very popular amongst national and international policymakers because of his knowledge and his clinical acumen and his research and work on ovulation induction. His research basically focuses on pathophysiology of both PCOS as well as premature ovarian insufficiency. So we are really lucky to have Professor Fawcer with us. And Priyanka, if you can stop sharing your screen, I can start my screen sharing so that we will, in brief, discuss about the Indian scenario first. And we would be very happy to know the inputs from Dr. Fawcer of on how to improve as far as the ovarian stimulation is concerned. So here we go. We should actually know the art and science of ovarian stimulation, and this requires a lot of skill. As we all know, ovarian stimulation is the most crucial step in ART, and it needs a lot of expertise. There are many challenges. If you, we all know that there are WHO class 1, 2, and 3 class of ovulation, where every class the approach is different and challenges are different. We are mostly in clinical practice are concerned with the problems with PCO on one hand and diminished ovarian reserve on the other hand. And of course, sometimes we also get cases of hypogonadotrophic hypogonadism, that is class 1 in our clinical practice. Now, all our recent guidelines have actually helped us in understanding the ovarian stimulation in a better way. And the two important guidelines which have come is one is the ESHRE guideline 2019 and then international evidence-based guideline for the assessment and management of PCOS 2018. And Dr. Fawcer has played a great role in actually the decision making and policy making and laying the guidelines on PCOS as well as premature ovarian insufficiency. So these two guidelines have helped us in managing the patients. Now, if we just look at the Indian perspective, we need to understand that how the Indians are different. Is it because of the ethnicity, or is it because of the economy, or is it because of the population? All these things we need to discuss in another 8 to 10 minutes. Let us talk about ethnicity first. And declining fertility is something which is today's reality. And I was just talking to Dr. Fawcett about this problem, which we are facing in India nowadays, and that is declining fertility. And there was a paper which was published in Fertility and Sterility in 2014, which is actually an eye opener for all of us. It says that ovarian age is 6 years ahead in Indians as compared to Spanish women. And so, friends, the time is ticking, and this is the 6 year study which we need to understand. And we need to understand that ethnicity plays a great role in the management of patients in India. And this is the study which has appeared in Gynecological Endocrinology, and this says that Indians, the IVF results are low as compared to the other European and American counterparts. They have concluded that ethnicity, like age, is a major factor, and it is an independent factor and a predictor of IVF. And one of the most important thing which I would like to tell you here is that despite of having two major factors in favor, that is young age and good antral follicle count, Indian ethnicity patients have poor IVF outcome. Indian women have inherited non-modifiable drawback of ethnicity and thus having low IVF success rate over white Caucasian women. And this is the reason why we should avoid prolonging duration of infertility. That is the reason why we have a social responsibility of counseling our patients that please marry early and have childbearing before the age of 30, because as the age advances after 32, we have experienced that AMH levels drop drastically low, and then the patients have problem as far as the fertility is concerned. So the indications of IVF, if you look at indications in India, we'll find that the diminished ovarian reserve is the major indication of IVF nowadays. Second comes the male factor, and PCO, tubal factors, and endometriosis, they are taking backseat. So, what are the solutions for DOR? We know that there are two solutions. One is either you stimulate or you go for donor program. So, we will discuss about the developments which are taking place in both the situations. One is the donor program, and here there is the issue of donors, and this is the latest development which has taken place in India on 25th January this year. There is a act, ART Act, which has been passed by the Parliament. This is a welcome sign. They have categorically said that exploitation of donors should be avoided, and therefore only a donor can donate only once in lifetime, and the donor cannot donate for more than 7 oocytes. Now the another point which is to be discussed is this will lead to the scarcity of oocytes, and also diminished ovarian reserve problem will be a major issue in the future. This will further add to the cost, and especially in low resource country like India, it may lead to further problems. So this is the problem with the donors which we are going to have, but this is a welcome sign because the exploitation of donor is also a major issue. Now, one more thing which I would like to discuss here is the changing trends in Indians. In Indians nowadays, more and more people are going for late marriages, and they are aware of the oocyte freezing. Dr. Fawcett, as we know that in Europe and America, oocyte freezing is very common. In India, the trends are changing, and nowadays Indian girls are also opting for oocyte freezing. And another thing which I would like to tell you here is that diminished ovarian reserve, the patients are strongly against donor program. A few years back, only men were reluctant for getting the donor sperms, but nowadays even women are reluctant to get the donor oocytes. And this is something which is happening in India, and this is because of the changing trends. Now, what is the solution for this? You may add stem cell therapy, you may give PRP, you may give adjuvants, but these are mostly empirical. And another option which is available is, of course, embryo pooling. Now, all these things are available, but embryo pooling is something which is happening nowadays, which requires a lot of expertise. And we need to understand the physiology of ovulation. We need to understand the cost and time involved in the embryo freezing. So this is something which is about diminished ovarian reserve. Another problem is of PCOS, and PCOS is something which is, as we all know, letrozole is now endorsed as the first line treatment for the ovulation induction in PCO. And we are lucky that if you just look at the letrozole as a drug of choice, initially there is a rise and fall, and now again a rise of letrozole in India. Once upon a time, letrozole was banned in India, But as we know that CC is no more a drug of choice. CC's position has been recently challenged. And the sad part is nobody respects age unless it is distilled and bottled. And clomiphene citrate is neither distilled nor bottled. And that is the reason why, though age old, this clomiphene citrate is no more a drug of choice. And letrozole is taking this as a first line of treatment for the treatment of PCOS. And we are lucky that in India this drug is available. There are still many countries where letrozole is banned. In India, it was banned initially, but now it is available, and we are using it routinely for the stimulation in PCO patients. OHS's free clinic is something which was a serious issue few years back, but the best part is now it is becoming a reality because antagonist protocol and agonist trigger is something which we all Indians are doing nowadays, and this is a wonderful thing which has happened, because of which OHS's free clinic is a reality in India. Cycle segmentation is something which we are doing regularly. Um, One more point I would like to add here is in ovarian stimulation, patience pays. If you look at the guidelines, and Dr. Fawcer is the best person to guide us about this, that the starting dose is very important. And very high dose is not going to help you. Not even 450, only 300 should be the starting dose. And there is no point in increasing the dose on day 5 or day 6. Number of days you should go do the stimulation is also important. And I guess that we Indians, we lack in patience. So we would like to learn from you about the stimulation protocol, how to go ahead and how to go for the soft protocols, which is the need of hour. A word about AMH. As we know that AMH and AFC are the two most reliable markers of ovarian prediction, ovarian reserve testing. And AMH is nowadays we are doing routinely AMH, but AMH is still an issue with some of the labs in India, because as you see, this is the something which I was reading yesterday, and I found that it is said that it should be noted that evaluation of AMH has not yet been accepted as an alternative to ultrasonography because of the problem with the laboratory, and you may get results which are variable, and then you may get confused, and that is the reason why still AFC is something which you rely more upon. But AMH is becoming popular and you are getting more and more good results with AMH, but some of the labs still do not give good results, and therefore there is a confusion over AMH. Before I sign off, I would just like to discuss with you about the outcomes and recommendations which are given in this study of an Indian expert panel for improved practice in controlled ovarian stimulation in ART patients. This is a study which has appeared in 2017, and this study have they have in this study they have studied various factors like number of oocytes to be obtained, and other factors like whether to give progesterone when the whether to go for the cycle when the progesterone levels are more than 1.5 on the day of HCG, and they have come to the conclusion that number one, number of oocytes should be between 10 to 15. That is the optimum number which gives you best result. Second point which they have noted is that is there any relation between cohort size and embryo quality? They have found that maternal age is important and not cohort size. The cohort size does not affect the embryo quality, and they have said that higher availability of euploid embryo is there if the cohort size is increased. Third point which they have said is about the gonadotropin, choice of gonadotropins, and does gonadotropin has any effect on the oocyte yield? If you look at the 2019 guidelines, they say that gonadotropins are gonadotropins. And if you use any gonadotropins, it is not going to matter. But the Indian study has come to the conclusion that recombinant FSH is better than HMG as far as ovarian stimulation is concerned, and the FSH should be preferred over HMG for ovarian stimulation. And the last point that they have noted is about the progesterone levels on the day of HCG, and they have said that even if the progesterone levels are more than 1.5, there is a controversy, and they say that you should not go for freeze-all policy. Now, this was in 2017, but I guess that nowadays there are many reasons why everybody is going for cycle segmentation. And freeze-all policy is something which is preferred by most of the IVF centers, even in India. So I think Dr. Fawcer will throw more light on this issue of cycle segmentation, and whether really we should go for freeze all policy if the progesterone level is more than 1.5, because this study says that there is no reason why you should do this. So these are the things which I wanted to just highlight. So here we have lot to learn, and we are lucky to have an expert like Dr. Professor Fauser with us. It is said that always walk through life as if you have something new to learn, and you will. This is so true for today's webinar on ovarian stimulation and various protocols. So, Dr. Fauser, this is all from my side. The stage is all yours, and we all are eager to listen to you, your pulse of wisdom, your experience, your expertise on the field of ovarian stimulation. Over to you, Professor Fawcett. Thank you very much.
Thank you. Let me see. Can you see my slide now?
Yes, sir.
Thank you very much. First, thank you for having me here today. I would like to thank the previous speaker. You brought up many relevant questions and not so easy to answer. So hopefully we'll get to those during the discussion session later. Many pertinent questions, and indeed all these separate issues that you mentioned, you know, that they would deserve a 1-hour lecture each at least. So what I would like to do today is try to give you the overall perspective of how I see ovarian stimulation, where we are at present, and how I think we should move forward. Indeed, it is not so easy, and ovarian stimulation has become so complex that it's very easy to get lost in the details. So much is being published, not all of high quality, so you get sidetracked very easily. So I always try to, and I say that during consensus meeting all the time, I say, let's keep it simple. Let's try to focus on the bigger picture and not complicate things too much. So that is what I would like to share with you today, bring you back to the basics. Indeed, I've been working in ovarian stimulation. It has been one of my core focus of research interest over a 30-year period. So I think I have a pretty much a view on where we are and what's going to happen. Just a bit about me, you've heard it already. I've been working at the university, OBGYN department, on different universities throughout my career. What is, I think, quite special in the Netherlands, that our infertility units, IVF units, if you will, they're all really big, all large size. And we do about 2,000 IVF cycles annually, if not more. And it's always within the hospital and within a university environment. So that's for sure why you see a lot of publications from the Netherlands, because they're all located in these university centers where there's a great push and incentive to work on innovation and improving care. What also helped me a lot looking at science is, of course, being as a referee and more recently as the editor-in-chief. I'm currently the editor-in-chief of Reproductive Biomedicine Online, RBMO. I've been chief editor of Human Reproduction Update. So it really gave me a different perspective on research, and also indeed sitting in the board of the Dutch Medical Research Council, next to being consultant and being involved in organizations. So as a starting point, I would maybe like to state the obvious. There are different forms of ovarian stimulation. And I think it's very important to make a distinction between those. And from my perspective, there are three different forms. And the terminology is not so very clear always. So number one, it's ovarian stimulation in the context of IVF. That used to be referred to as COS, controlled ovarian stimulation, or COH, controlled ovarian hyperstimulation. Those terminologies are banned. So I would like you to appreciate that. And in the new guidelines, you see it is just ovarian stimulation. And I've been involved in these ICMART, WHO guideline discussion, and I say there's nothing controlled about ovarian stimulation in the context of IVF. If it would be controlled, we wouldn't be sitting here. Then it would not be a problem. It is uncontrolled, and that's why it's so difficult to manage here. So the terminology, I said to all the people involved in the guideline, I say the term controlled ovarian stimulation is wishful thinking and has little to do with reality. So let's be honest. And indeed, finally, after much resistance, terminology has now changed. So it's ovarian stimulation. The only thing which is not so very clear, that the whole container is also, all forms of ovarian stimulation is referred to as ovarian stimulation. So number two is ovulation induction. And this is a very, very different, indeed, in both cases you stimulate the ovaries, but in a very different condition. I'll show you in a bit. And then there's also ovarian stimulation in the context of IUI or empirical, as I'm sure you're aware. And it's very important to realize that the link between ovarian stimulation and multiple pregnancies is really controlled. Because as we know, in vitro fertilization, you can control the number of embryos transferred. So here you can control. But in the other two forms, in ovulation induction and ovarian stimulation for IUI, there is in vivo conception, and therefore it is much less controlled in terms of the number of oocytes that are being fertilized, and therefore multiple pregnancy rates. I believe it's very important to make this distinction, and people still make mistakes all the time. And you see this in journals, and you see this in titles. Then you know, there's still many papers published with the title Ovulation Induction in IVF. And of course, you can do ovulation induction in the context of IVF, but that's very rare. So what I think most people mean is ovarian stimulation in IVF and not ovulation induction. So terminology is not just semantics. Terminology is very important to pinpoint what we are doing. And indeed, this is a review some years ago in the Lancet, focusing on multiple pregnancies in relation to infertility treatments. And it's interesting at that time, and of course that's not completely representative for today, but still not that much has changed. Are you aware that in the world, around 1 in 100 children born are from IVF, globally? About 1 in 2 of all twin pregnancies are from infertility treatments. And about 90%, 9 out of 10 of triplet and higher order multiple pregnancies are from infertility treatments. That is quite disturbing information, isn't it? And here you see it is no surprise that since we started to do infertility treatments on a wide scale, you see that there's a huge global increase in twin births, but particularly in triplet and higher order births. And we all know what that means in terms of pregnancy complications, perinatal outcomes. So again, this is not completely representative, but if you see still today how often IUI and ovarian stimulation is applied with not very reliable national registry, how often more than 1 embryo is transferred. So still, we as infertility specialists contribute still a lot to multiple gestation. And our obstetrical colleagues can easily tell you how much trouble that usually means. So ovarian stimulation in different forms, ovulation induction versus ovarian stimulation. Again, we have to realize that these are very different forms of ovarian stimulation, where both the starting point and the desired endpoint differ. With ovulation induction, most of the time, we talk about PCOS patients. So these patients do have follicles, but there's no dominant follicle growth and no ovulation. So there, it is an abnormal situation. And what we try to achieve is the normal monofollicular growth. This is the starting point. This is the end point. In the context of ovarian stimulation for IVF, under normal conditions, most of the time, what is the end point here is the starting point there. Women with ovulation who undergo IVF, the great majority of these women, they have normal menstrual cycles. So there they do have monoovulation, and there the aim is to induce multiple follicle developments. I think it is as simple as that. Differences between ovulation, induction, and ovarian stimulation apply to both the starting point of stimulation and the desired endpoint. And then a remark of caution and maybe also of modesty. We think that we can control everything with ovarian stimulation in daily practice. We feel like the big magician that can do whatever we want and control everything we want. Reality is quite sobering and different, because what we now know from starting basically from rat studies initially is that the trajectory of follicle development from the primordial resting follicle up to the pre-ovulatory Gravian follicle probably takes at least 6 months. And in reality, in real life, these follicles become dependent on gonadotrophins and therefore can be influenced by us only during the last 14 days of that long trajectory. So all these factors that regulate early follicle development are beyond our control and quite often beyond what we know. We don't really know yet which are the most important determining factors. Some believe growth factors, others believe BMP growth factors, others believe that it's AMH. Now, it's not clear yet, but so again, what we can influence is only the last phases. And if you know this biological concept, and then I go back to the first presentation again, that diminished ovarian reserve is a common problem for us. Think about this. Diminished ovarian reserve has to do with a reduced number of primordial follicles. How can we even believe that we can manipulate that, fix that, by changing gonadotrophin doses? That goes beyond all biology. This is where the problem is, which has nothing to do with gonadotrophins. So again, we have to be modest and realize what the limitations are of what we can do. Now, then there are many different compounds nowadays, and some are even under development. The analogs, the gonadotrophins, anti-estrogens, aromatase inhibitors. We get more and more other compounds as add-ons being used. I will not go in detail here. And what is the most recent development is the kisspeptin, the GPR54 receptor agonist and antagonist. So it's a pre-GnRH. This is still in the experimental, but there are several phase 3 trials undertaken and on its way. So for sure, we're going to have these compounds available within the next 5 years, both in terms of to stimulate the pituitary ovarian axis as well as to inhibit. So be prepared, and I think it's really nice to think about what we can do. So the rest of my presentation, I will split into two. The first part about ovulation induction, and I will spend most time there because there's not much interest and not much research going on there. People are forgetting this area. And the other is ovarian stimulation in the context of IVF. So ovulation induction treatments, as mentioned, not too much has happened. Next to the, I'm sure you're all aware, the Rotterdam ASHRAE ASRM consensus organized in Rotterdam. That was all because I organized these series of 3 together with my colleague and friend, Professor Basil Talatzis from Greece. And we organized the second one on infertility treatment in PCOS. This was in 2008 in Thessaloniki, the home city of Brazil. And this is what the conclusions were, and I will not go in detail. At that time, again, 2008, the general consensus was clomiphene citrate is still the first line compound, but also I think what was at the time new, that there was a lot of emphasis on pre-conception care. It's not rushing to drugs right away, but we be aware of the health of women, and that the health of women not only affect their chance to get pregnant, but also is directly related to the chances for pregnancy complications and suboptimal perinatal outcomes. So very, very important in terms of diet, exercise, other measures if needed. Now, clomiphene is first line at that time, and I think that's still a second line gonadotropin treatment and laparoscopic ovarian diathermia. You can argue, I will not do at this stage, what would be preferred, and is it dependent on circumstances, yes or no, and third line IVF. And this is still, except for clomiphene versus letrozole, the aromatase inhibitor, as you heard previously, this is still the algorithm supported by all guidelines. But we know in reality, life is quite different. Of course, there are no global data, but we all know that many people with PCOS are exposed to IVF as first-line treatment. They don't go through the trajectory of ovulation induction at all. And I think it's fair to say that there is no solid scientific proof to defend such a strategy. It may be with single embryo transfer, it may be with better control of multiples, but direct head-on comparison between IVF as first-line treatment versus conventional ovulation induction, those studies do not exist. So there may be other reasons why PCOS patients are exposed, maybe prematurely exposed to IVF as first-line treatment. And there may be financial incentives and others, but it may not necessarily be in the benefit of patients to do so. And in that respect, we are losing interest in ovulation induction overall. And you can see that in lack of progress. This guideline has been mentioned. They go into great detail about ovulation induction. Indeed, as mentioned previously, the only new clinically relevant recommendation is that letrozole should be considered first-line treatment rather than clomiphene citrate. Published both in Human Reproduction and Fertility, as you can see. There are some subsequent papers. This is a meta-analysis with added, I think, proof that in the RCTs directly comparing letrozole versus clomiphene citrate, pregnancy rates are increased in the letrozole group. On the other hand, because we did a lot of studies, I'll show you a bit later on clomiphene citrate, as I see it, the overall pregnancy rates are relatively low in the clomiphene arm. And quite often we have better results with clomiphene than is published with letrozole. We can argue whether it's related to ethnicity, body weight, hyperenergenemia, but okay, overall, the recommendation now is letrozole as first line. And it's also shared in this publication, you see letrozole versus clomiphene citrate, including 45 trials, 8,500 patients. So yes, from a science point of view, it is solid that letrozole is the first line. So to tell you a little bit about our trajectory and our interest over the many years, we have seen thousands of PCOS patients, mainly in the context of infertility, but over the years, our interest changed, our research interest. So first it was really only focusing on infertility therapy, but later on, we have been looking a lot at pregnancy and pregnancy complications, perinatal outcomes. We followed the children of these pregnancies. I will not go in detail here, but it's all published. So if you're interested, you can easily find this in PubMed. So again, we have not only been focusing on achieving pregnancy in women with PCOS, but also how are they doing in terms of pregnancy complications, gestational diabetes, small for gestational age, and children outcomes. So you see this, I still like this. If you talk about ovulation induction, this is really classical endocrinology. What should you do in terms of assessment of if a woman aims to get pregnant and is oligo or amenorrheic? And again, this goes back to the 70s. Think about it. It's 50 years ago that based on a simple assessment in serum of FSH and estradiol, you can make a distinction between WHO group 1, 2, and 3. And of course, in everyday practice, the great majority of patients that we see in the context of infertility is normal FSH and normal estrogens and WHO group 2. And indeed, I will not go in detail whether recombinant FSH or HMG combined preparation, but what I still see today, patients that are referred to me that turn out to be hypogonadotrophic, hypoestrogenic, so WHO class 1, and then they were treated with recombinant FSH alone. And then they didn't see the outcome they expected, and nobody understood what was happening. And then sometimes they changed the preparation for recombinant. This is a classical mistake, textbook mistake, because this group does not only lack FSH, but it also lacks LH. And if in this group of patients you give FSH only, you will not be able to stimulate properly because estrogen levels do not rise. Because granulosa cell aromatase activity, that's what FSH does, converts androgens to estrogens. But if there are no androgens, because LH levels are low, estrogens are not going to rise. So a classical mistake. And I think a nice example why it is relevant to still today to do this kind of investigation. But for reasons of simplicity, I will only focus on this group, the WHO group 2, which the great majority represents PCOS. Let's skip to one Glomithine. So we have been doing this prospective cohort follow-up studies where first-line treatment, you see we started with this cohort in 1993, so already quite some time ago. First-line treatment Glomithine, second-line treatment gonadotropins, and only thereafter IVF. And we know that this approach can be effective, but certainly not by all. So the question we asked ourselves already in the early days is, could we predict the woman that will do well with conventional ovulation inductions versus the woman who don't? So in Glomithine, in our patients, this is cumulative ovulation rate and cumulative pregnancy rate. So when you start with Glomithine citrate, and again, with letrozole, it will be slightly better, but not that much. You see that you have, after 6-9 months, you have a cumulative ovulation rate of about 75% in the patients that we treat every day in the Netherlands. 3 out of 4 will ovulate. And within this ovulation, about half of those will actually have an ongoing pregnancy. So you can argue whether it's good or bad. So it's about 1/3. So it takes you 9 months for 1/3 of these women to have an ongoing pregnancy rate. And of course, at low cost and low risk. But the bad news is that 2 out of 3 of the women you start, they fail to have success. So it takes you 9 to 12 months to discover that the majority of patients, for them, it doesn't work. And of course, for those, it has been a waste of time, these 12 months, because they ended where they started, not being pregnant and not having children. And so I think towards the future, what we should dwell on much more is not group medicine, where we have a regimen that may apply to everybody, but where we should be much more focusing on individualized care based on patient characteristic. And this is all still fairly premature, but it's possible. So we have been looking at, and you remember you have seen this, the ovulation and the pregnancy. And so the predictors for ovulation, what were the women likely to ovulate or to not ovulate? That is the free androgen index, women with elevated androgen levels, and we had a prediction model. I will not go in details. So we were fairly good with an area under the curve of 0.83 to predict a woman that would not respond to clomiphene citrate. And we have developed an algorithm, a nomogram, if you wish, where we, on an individual basis, based on these characteristics, the age of women, body mass index, their cycle characteristics, and free androgen index, to make an individual assessment of their chances to have a live birth. We published this extensively with one of my PhD students from Iran originally, Imani. So you can go back there. And this is preliminary, but I still believe promising. There has not been too many follow-up studies. So if you look at the overall cumulative pregnancy rates with clomiphene as first line and gonadotropins as second line, and here we only focused on singleton live birth, not multiple, singleton live birth, we reach after 1.5 years about 70%. Think about it, that a fairly cheap regimen will result in about 7 of 10 women with PCOS, Dutch patients, in singleton delivery. And we looked for predictors there as well. Can we assess which are the factors that determine whether a woman is more or less likely to be successful with a classical ovulation induction? And you see here, it's the age of women, the glucose, and the duration of infertility. Again, all this is published. And there was one follow-up study by Rick LeGros group in the US that also looked at which factors predict pregnancy with clomiphene citrate. This is, I'm not sure whether you're aware of this, in cardiovascular research, this is very common, where people calculate based on metabolic syndrome factors, your 10-year risk of a cardiovascular event. And there you see this kind of diagrams. So red, of course, means bad news. So you have a high chance. Green means good news. You have a low chance. And here as well. So based on BMI, age, etc., for an individual woman sitting at your desk, you can assess her chances to be successful with this treatment or not. And I think that would really help if we would focus on this more. And also to inform you, there have been 2 studies. I guess you've seen them, ovulation induction studies performed by Rick LeGros and many other centers in the US. This is a New England paper. And here, basically, this is the study that killed metformin as first-line treatment. At that time in the US, all PCOS patients were treated with metformin. But here, when you look at the cumulative pregnancy rates, it showed that clomiphene, or the combined treatment, clomiphene metformin, is much better than metformin alone. So I think that makes sense, and it helps to say, metformin is not a good choice. But when you look here at the right-hand side of the slide, there you see, and that's related to what I tried to propose, is look at this. Sorry. You will see that BMI is also a very great determinant for success of ovulation induction. So obese women with a BMI here above 30, they have a much lower chance than women with a BMI below 30. You see half the chance, regardless of the medication. So you see, it is here you focus on the drug you receive, but you see that the patient's body weight is as important as a predictor for chance of success than compared to the drug you receive. And here, this is a more recent study from the same group. Again, a big multi-center randomized controlled trial comparing letrozole versus clomiphene. I think this is the first big trial showing that letrozole is better. It shows live birth rate, cumulative over a given period of time. And here you see that letrozole is much better than clomiphene. But, again, this is particularly, this difference you can still see in the very obese women. The US population is overweight is very prominent. So in the women with a BMI above 40, here you see a distinct difference between letrozole and clomiphene. But if you have a BMI of less than 30, there is virtually no difference. So you see that the letrozole versus clomiphene different effect is body weight dependent. And that may be the reason that, for instance, in the Netherlands, clomiphene is doing quite well. Why? because we don't have that many women with a BMI above 30 in our country. So you see, life is not that simple in terms of mass medicine, something that works for everybody. It is population dependent. So then, and I'm aware of the fact that particularly in your part of the globe, myo-inositol is frequently used. I think it's fair to say that even today, the use of this drug in this context is promising, but not more than promising, because well sample-sized studies do not exist. There are several studies, and I summarized them here, but sample size is small, using different endpoints. So it looks pretty good, but we don't really know, because the solid scientific evidence is not available. And this is, although this compound is already used, I guess, for around 10 years in this context, it is a bit worrying that still 10 years later, globally, we expose many women to this compound without the solid scientific proof. So rather than developing something that works for everybody in ovulation induction, I believe that particularly in ovulation induction, there is a great need for more individualized, and it might help very much, you know, if we talk about the average chances of a cumulative live birth with ovulation induction, and you can develop strategies around it. But I think it would help a lot for individual choices if you know in advance that the patient has a very good chance to achieve a pregnancy, then you can strongly recommend that approach. Whereas if a woman, based on her personal characteristics, has a very poor chance of getting pregnant with such a, then you can skip it and say, you know, then it may be just a waste of time to wait 12 months for 10% or 15% chance. Then it may be better to go to ART right away. But again, such studies have not been undertaken so far. So next to the compound, we have to realize that there are many other factors that has also been mentioned previously. It's the patient, about ethnicity, it's body weight, other characteristics like hyperandrogenemia, patient managers, doctors' experience. I'm afraid to say that there are less and less gynecologists that have great experience with ovulation induction, so they feel much more comfortable with going to IVF right away, and the context in terms of period conception strategies, etc. Then we move to the next part, ovarian stimulation and ART. The guideline has been mentioned. It's a very, very detailed guideline. I think not many surprises there. This is very much evidence-based, so they did meta-analysis and blah, 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 the whole thing, what is good and what is not so good. It's good to be aware of this. It's good to know the conclusions, but there was nothing really unexpected or spectacular. And here again, what I would like to stress is, and it was mentioned by the previous speaker, I think you mentioned what is preferred is between 11 and 15 oocytes, what you would generate. To be honest, I'm not sure whether that's the case. That may be the case with the conventional form of stimulation, and focusing on many eggs, because the idea is that many eggs means greater chances for success. And everybody refers to the Sunkara HFEA summary. I remain unconvinced for many different issues. And this is a mixed bag. It's a post hoc retrospective analysis, heterogeneous protocol. So it's apples and oranges together. It's over many, many years where IVF practices changed. Only fresh embryo transfer is taken into consideration, and no attention is paid for cost, discomfort, complications. So I think I think it's fair to say it is not fair to only focus on fresh transfer results. And this has been over-interpreted by everybody, by the authors, but by everybody else thereafter. And I'm a non-believer. This is too simple. Life is not that simple. I mentioned FSH ovarian stimulation for IVF is not controlled. It's wishful thinking. It's what we wish. It is not controlled. So often still today we are surprised, you know, we give our favorite regimen and then either the response is too much which we know, oh, we have to be careful because it's dangerous, you may OHSS, or it's not good enough, and then we know that, that there's poor response. And of course, this is very common in medicine. You know, if it's too much, your intuition says, you know, you lower the dose. And if it's not enough, your intuition says you increase the dose. Now, good luck, and it gives us a good feeling, but we know it doesn't help. Again, if you go back to ovarian biology, you understand why. So there's only one time when it's important to decide about the dose, and that is when you start with stimulation. It is as simple as that. I will not go into details. This is for a WHO a guideline development that together with Cindy Farquhar and Cheryl van der Poel, we summarize the literature and we try to say, can we get a feeling for how complicated did we ovarian stimulate? Because it's not just the stimulation, it is pre-stimulation regimens, it is post-stimulation regimens, it is luteal phase regimens, there is co-treatment with agonists and antagonists. Just imagine how many different combinations of all this you can bring to, you can easily design 1,000 different stimulation regimens with all these variables. So can't we agree that we have really been overdoing it and have been making it far, far too complicated? This is, I like this, and I've been showing this for 20 years now. This is what we do with ovarian stimulation, hyperstimulation, if you wish, in the context of IVF. Boom, you know, we give a lot of stimuli, a lot of FSH, and we push everything out we can get. Isn't it? That's what we do. We get a very heterogeneous cohort. We may like to wait even longer, but we know we can't for different reasons. So then based on the larger size, we give HCG, and then we puncture whatever we can get between 10 and 12, 20 millimeters. And then we just all group them together. And from then on, we believe that they're all the same, these oocytes. And I say, you know, dream on, colleagues. These oocytes are not the same. And we know that because, you know, they don't all fertilize. You know, even in good clinics, it's about of the oocytes that you generate, usually the fertilization rate is somewhere around 70%. That still means that 3 out of 10 oocytes that we generate with this strong stimulation, you know, they go in the trash can right away because they don't fertilize, let alone what happens after fertilization. So oocyte numbers is not the only endpoint. And we know about, and here again, biology is not that simple. It's actually pretty complex. So over the last 10 years, there has been more and more interest. What do we do with all this ovarian stimulation rather than getting all these oocytes out? We affect the luteal phase. And I think there's more focus on the luteal phase now, but still today, although we talk about luteal phase supplementation, we still don't really understand what happens. It also affects endometrial receptivity. So chances of implantation, that's one of the reasons for the freeze-all approaches, that you don't want to transfer in an endometrium which has been exposed to abnormal steroid levels. But now there's also more and more indication that it may affect placentation, and it may affect pregnancy complications, maybe even perinatal outcomes. Just the steroids during the follicular phase via placentation. And last but not least, and there has been a lot of debate about this, does it affect embryo quality and aneuploidy rates? I think still unsettled today. So you see, simplified thinking that more oocytes means better clinical outcomes, I think remains to be seen. And I would question that seriously. This is one paper. There are many, many others saying the same thing. An outstanding IVF center like Brussels, they looked at their own results and they say, you know, in young women, we need about 20 oocytes for one live birth. In other words, we create 19 oocytes in vain, because out of the 20, only one gives rise, and potentially, of course, any oocyte can give rise to a birth, but only 1 in 20. And with increasing age, you see 1 in 40, 1 in 100. And of course, we know in women above 40, we never get 100 oocytes. So if you look at it from the different angle, you could say we have created a very, very redundant system. And is this really what we want? And is this really the way forward? I question that. So we should start thinking seriously about the number. What should we aim for under optimal circumstances? And yes, I agree with the conventional stimulation. It may be between 11 and 15, but with milder stimulation, lower may be as good. And there are some studies showing that this is the case. Now, AMH, now you see it everywhere. I fully agree with what has been mentioned. AMH as a substitute for ultrasound in PCOS is not settled as yet, mainly because of assay reasons. I do believe that AMH is very important in ovarian stimulation for IVF. This is studies from our group, meta-analysis on how good AMH is as a predictor of ovarian response. We all know this. You see area under the curve, which are very favorable. And now a company, I will not go in details, has developed their new recombinant FSH with an algorithm where AMH is a very important factor. So yes, it can be used to simplify and individualize ovarian stimulation for IVF. I will also not go in details about mild stimulation, but we have been working on this very hard for a long, long time. There's more and more others that show in our guidelines. I don't know whether you're aware, the ASRM, particularly in women with presumed low ovarian response, there the ASRM practice committee guidelines said you can as well do mild stimulation as conventional high dose stimulation because it doesn't make any difference. So I think stating clearly that this is predominantly an ovarian abnormality that cannot be overcome by increasing stimulation. So towards conclusion of my presentation, when we talk about ovarian stimulation for IVF, we cannot simply say the more the better. It is much more complex, and it relates to cost, complexity of treatment, the need for hospital visits and monitoring, and therefore access to care. It relates to complications for sure, OHSS, and also it relates to burden of treatment and maybe dropouts. So when you talk about optimizing IVF, we should have real life endpoints, like how effective is it, how safe is it, and how cost effective is it. And certainly in the lower and middle income countries, of course, cost effectiveness is key, because in many countries in the world, still the great majority of women that have a clear indication for IVF don't get it because they have to pay out of pocket and it's too expensive. So I think the way to move forward with ovarian stimulation is not the one size fits all. It is going for precision medicine. We see that in many other areas, and in the way in reproductive medicine, we are lacking behind. If you want to read more about this, I just wrote an editorial on fertility and sterility published this month on the use of big data to inform individualized ovarian stimulation for infertility care. We still have a long way to go, but I truly believe that that's where we should aim our efforts. Thank you very much for listening, and of course, I'm very curious to entertain your questions and comments. Thank you.
Excellent presentation, Professor Foster. Thank you very much for such a lucid presentation. You have very nicely explained about the various issues in ovarian stimulation and how to optimize success rate in IVF. And also not only IVF, in the non-IVF cycles as well. So Priyanka, shall we take a few questions?
Yeah, I see, I see some questions in the chat box.
Yes, sir. So,
Give me a minute. So the first question is from Dr. Vijay Chavan. His question is, do we do ovulation induction with Glomithine and letrozole? Any study regarding that?
So there is a major echo, so I didn't really understand your question. Could you repeat this, please, slowly?
Yes. So there is a question from Dr. Vijay Chavan. His question is, do we do ovulation induction with Glomithine and letrozole? Are there any study regarding those?
Yeah, a great question. I think there is nothing wrong with following the recommendations and use letrozole as first-line treatment for ovulation induction in PCOS. That's fine. I just told you some of my reservations regarding the study, and particularly because it may be different for different patient population. It may be dependent on body weight. So there is room to individualize. But again, we don't have the scientific proof for that yet. So for the time being, yes, letrozole is fine. Although, as mentioned by the previous speaker, letrozole is, there are quite a few countries where letrozole is not available. Or it's still forbidden to use in the context of infertility.
Yes, I'll go to the next question. This is a question by Dr. Meghashree Deshmukh, which says that please give us protocol for severe PCO with young age. Married life 3 years. What would be your gonadotropin dose, and would you add antagonist to these patients? Okay, so she is asking a particular question regarding a patient who is.
No, but very good, very good. So first, if you mentioned that the patient is young, age, so I would counsel her that we have the time and that we should not hurry. So we should go for the low, maybe the lower chance treatment first, because if it works, that's great, and then there's not too much money and risk involved. So I would still underdose, dependent on, because you mentioned about age, I would also like to know her body weight and her androgen levels, because I know that those two factors next to age are also very important. I would also like to know her glucose insulin ratio, her extent of insulin resistance, and why, because we know, and we've studied and published that glucose insulin ratio pre-conception is a strong determinant for gestational diabetes. So once you achieve, so it is not just a focus to get them pregnant, but also, of course, the focus should be a healthy baby, and therefore we should mind pregnancy complications also. So what would I do with the gonadotropin dose? If it's a regular PCOS, I would just start with the regular 75, and some would start lower with 50 IUs per day.
Right. So I think low dose protocol is the best option here.
Low dose is absolutely the best option. And the worst that can happen to you is that you later on say, you know, I wasted some weeks because we had to increase the dose because of non-response. But that's much better than the other way around, that if it later on turns out to be that you started too high and all of it looks like, you know, these ovaries, they can sort of explode and increase in size hugely, have all these follicles develop. That's not what you want.
Exactly. So just a sub question on this. You are talking about this glucose and insulin ratio. So what about fasting insulin as a, because nowadays the guidelines say that fasting insulin is no more investigation of choice in PCO. So what is your view?
Yes, fasting insulin also would be a good marker. Some do a glucose tolerance test.
Yes.
So there are different measures and there are different views based on which society you look at. They all have their guidelines. Fasting glucose is fine.
Right. So Priyanka, can you take the next question?
Yes. So this question is from Dr. Ramesh. He says that he has found that with letrozole compared with Glomithine, the oocyte number of protein is less and the progesterone profile is altered. What does this mean in terms of results, because it is not always giving better result?
It's a very good question, and I believe it's fair to say that around letrozole, there has been not many studies on mechanism of action. How does it really work? So it has been developed in an evidence-based medicine guideline type of thing, that they did RCTs comparing one compound versus the other. On the other hand, and I elaborated on that in a book chapter, we don't know very much about the mechanism of action of Glomithine citrate either. It's quite surprising that this is still the most used drug in infertility care for 60 years now, 60 years. And we don't really know, you have different forms, the cis form and the zoo form, and some have a longer half-life and more receptor affinity. And when you look, what happens over time with LH levels or with progesterone levels, it is rarely studied. So it is quite surprising that we have been using a compound that we don't really understand carefully what it does. And I think the same applies to letrozole.
Right. Sir, I guess as George has said, letrozole, the number is less. I think that is what we want. Basically, letrozole is giving you less number of oocytes, but at the same time, it is giving you good endometrial lining. And in PCO patients, if you prefer letrozole over CC, you have a benefit of getting less oocytes, which is going to give you the less chance of ovarian hyperstimulation as well as multiple pregnancies. What is your take on this?
Yeah, no, 100% in agreement. And as I mentioned in one of my slides, so ovulation induction, by definition, you do by women that do not ovulate by themselves. And by definition, what you aim for is monofollicular development.
Exactly.
You don't often get that because we know in PCOS, only one follicle beyond 10 millimeter is very, very rare. So quite often you see multiple follicles developing up to 13, 14 millimeter. So indeed, the more mature follicles, the better. We need at least one. That's what we aim for, but not we aim for not having more than one.
Yes, and Professor Fawcett has rightly said that often the controlled ovarian hyperstimulation becomes uncontrolled.
Yeah.
And and that is what we don't want, actually. Right. So now I think the next question is by Dr. Meghash, which says, please elaborate about the dosage in minimal stimulation protocols in IVF.
Yeah, that too is a very good question. It is Professor Geeta Nargund from London and myself. We have published also recently quite some reviews. I have to say that mild stimulation has become a mixed bag. Using oral compounds only, using letrozole, insulin sensitizers, the combination of oral and gonadotrophins alone. So it is also apples and oranges. I think the unified idea is that we aim for getting the same clinical outcomes with simpler, cheaper stimulation and with fewer oocytes. That's the aim. And we have been doing our studies with mild stimulation in, let's say, in the early days of mild stimulation, that was with low dose gonadotrophins alone. And again, good dose finding studies, whether you should start with 100, 125, 75, those studies do not exist. So it is not sufficiently studied, let alone what it adds if you add oral compounds on top of gonadotrophins. So you're asking a question that I cannot really answer except for how we did it, our personal experience.
Yes, sir. In continuation with this question, I would just like to ask you about your experience on letrozole, the use of letrozole in IVF minimal stimulation protocol or mild stimulation protocols. Can it add to the, it will help in decreasing the cost factor?
And what I have seen is most of studies, it is not letrozole alone, but it's letrozole combined with gonadotrophins. And right. Yes, it may be the way forward, and certainly it will make it more cost effective. It will reduce cost. But the studies that I've seen are all fairly small sample size, and therefore it's difficult to really understand what it means. You should have, of course, a well-powered randomized comparison of any given, let's say, cheap stimulation regimen versus the conventional one, and then see how it presents itself in terms of number of oocytes, in terms of, but there's only that, and also in relation to mild stimulation, there is, I think it's not in your country available yet, Recovel, the new human recombinant FSH, that has been developed with a dosing algorithm. I know that also from the Asian Pacific region, several studies have been published recently, and there initially they did comparative trials with the conventional stimulation, and there you see, because the numbers are big, that with the algorithm you have less oocytes, you have less complications, which is not surprising, but the clinical outcomes are at least as good. So I think this is the most convincing data, because the numbers are so big that you don't necessarily need the maximum number of oocytes to get good clinical outcomes. And for me, that is in favor of mild stimulation. This is evidence generated for different reasons. The one that introduced a new compound, but it shows that you can reach the same clinical outcomes with a reduced number of oocytes.
Right. I think the next question by Dr. Shilpa is the continuation of the same question. Can we add tablet letrozole in step-up protocol to gonadotropins for all control ovarian stimulation? That is what she has asked. Letrozole for all.
Based on theoretical considerations, I would say yes. But if you ask me, is there strong scientific evidence to back that up? My answer would be no.
Right. Are there any more questions, Priyanka?
No, I think that was the last question.
Okay. So I guess Professor Fawser has given elaborate answers to almost all the queries by all the delegates, and it was an excellent presentation. We have the next thing in line is kisspeptin, as Professor has rightly said. So we all are looking forward for this breakthrough in ovarian stimulation. Maybe in a couple of years, we'll come to know more about kisspeptin, and in next 5 years, we will get this drug available for routine use in clinical practice. Then I think we all should go with the nomograms developed by Professor Fawser, which will help us in predicting the ovulation induction and predicting the dosage and everything. As he has rightly said, metformin alone is not a good choice for ovarian stimulation. It has to be in combination with letrozole. And I think the most important point which you have added is about the lifestyle and weight reduction, and about the relation of this BMI and its impact on letrozole. If the BMI is very high, then maybe letrozole is a good choice. That is what you have added. That was something which was new. Then I think so about the heterogeneous protocols, sir. Before I sign off, and just one more point which I would like to ask you is about your take on the FSH followed by HMG protocol, which is very popular in our country. To it is cost effective, and as you rightly said, LH is something which needs to be added to FSH to get better results. So what is your opinion on this protocol, where we give FSH for first 5 days followed by HMG for another 5 or 6 days?
I anticipated that a question like that would come up. The so-called mixed protocols, I know, very, very popular. How can I say it politely? I think the scientific basis for doing so is not so very strong. So I know it is widely applied. I know it works. So I think there's nothing wrong with that. But also I know that many people are strong believers that it's better. And I always ask to those people, show me the proof. Show me the proof that it's better. Because I know it's not there. It doesn't exist.
Right.
So it's more the emotion of the doctor than anything else.
Right. Well said, sir. So before Dr. Priyanka, I think we should have a final word on ovulation, ovarian stimulation by Dr. Foster, and then maybe we can
Yes.
end the webinar.
I think I've said enough. So thank you very much. I would like you indeed to think about ovulation induction, and also in terms of your training programs, because I believe that if we don't change the current paradigm, ovulation induction will be gone 10 years from now. It will no longer exist. And please be reminded, ovulation induction has a much longer history than ovarian stimulation for IVF. You know, the first compounds for ovulation induction, they were introduced in the late 50s, early 60s, so decades before IVF. So I think it would be a waste and it would be unjust to ignore ovulation induction and to not further work on improving and individualizing these treatment regimens. That may be a good statement to end my lecture with.
Thank you, sir. A very important take-home message for all of us. Over to you, Priyanka.
I would first like to thank Dr. Foster and even Dr. Shembekar. Thank you, both of you. You have solved like a million queries even I personally had, and I'm very sure that everybody who has participated in the in the conversation today have learned a lot from you, both of you. Thank you so much. Thank you very much.
Thank you.
Thank you for listening. Bye-bye.
Bye. Thank you.
Bye-bye.